Welcome to POTUS 2016, where we keep watch on the Oval Office and pour cold, hard facts on the overheated political rhetoric. The campaign slogan is easy, but to actually repeal and replace Obamacare is hard. How fully, how fast can it be done? And who's likely to be left out in the cold? Also today, in our Evidence-Based Politics segment, the opioid epidemic. It's killing about 30,000 people a year. Are there solutions the new White House should get behind? But let's begin with this week's transition headlines. Since we last met, Donald J. Trump officially became president-elect as the Electoral College met in state capitals across the country. Despite protests, only 7 electors defected from their party's nominees, and most of those were supposed to vote for Hillary Clinton. Also this past week, Trump named a few more nominees to top jobs. He would like Vincent Viola to be Army Secretary. Now, Viola is more than just another wealthy guy who spent time on Wall Street. He's also a West Point graduate who helped found an anti-terrorism center there, and he owns the Florida Panthers hockey team. And Trump has asked bankruptcy lawyer David Friedman to be ambassador to Israel. Friedman questions the need for a Palestinian state and has likened left-leaning Jews in the U.S. to Jews who helped the Nazis during the Holocaust. And to be his budget director, Trump has chosen Tea Party and small government advocate, Congressman Mick Mulvaney from South Carolina. A budget director can help nix such things as environmental regulations by scoring their costs way higher than their benefits. All right, now let's delve into the first of today's topics, the fate of President Barack Obama's signature legislation, the ACA, the Affordable Care Act. In great part because of the ACA, a record 88% of American adults now have health coverage. And fearing its repeal, record numbers have been signing up at the last minute. But the program has problems. Here's Trump's nominee for Secretary of Health and Human Services, Senator Tom Price, back in June, promising some things he says will be much, much better.
A healthcare system that works for patients is one that must respect the physician-patient relationship. And so what we do is incentivize the highest quality of care without bureaucratic intervention. This better way. This plan right here puts forward common sense, positive solutions for Medicare, for Medicaid, and for the larger healthcare arena.
What Dr. Price hoped to move forward at that American Enterprise Institute forum was House Speaker Paul Ryan's health plan and his own. So what's the crux of the GOP approach? To understand the economic and political forces driving the issue, let's dig into the weeds with Manhattan Institute fellow and director of health policy there, Paul Howard. He was part of the Healthcare Policy Advisory Group for Mitt Romney's 2012 presidential campaign and is co-author of Unlocking Precision Medicine. And Sherry Glied joins us as well. She's a former assistant secretary in the Department of Health and Human Services and has advised lawmakers on both sides of the aisle on health policy. She is now dean at NYU's Robert Wagner School of Public Service. Glied wrote Chronic Condition about the never-ending process of healthcare reform. Welcome to both of you. Thank you for coming. Sherry Glied, why is it a never-ending process of healthcare reform? And it's not just in the United States, right?
Oh, that's right. I mean, in Germany, Bismarck brought in universal health insurance in about 1870, and the Germans revisit that legislation roughly every 5 years. So we're not strangers. We're not unusual in this. You know, healthcare reform brings together a lot of different conflicting ideas. One is, I think, a shared understanding among almost everyone that healthcare is special in some way. Jim Tobin, the famous economist, said people want to narrow the domain of inequality. Everyone's perfectly happy if some people can shop at Tiffany's and other people shop at Claire's, but they're very uncomfortable with the idea that your health care will really depend that much on your income. So we have this idea that we want some level of equality here, and ranged against that, we have the fact that what healthcare is changes all the time. So it wasn't such a hard thing to make healthcare equal in 1930 when a visit to a doctor was likely to do more harm than good. But it's a lot harder today when we have all these expensive treatments, all this potential, and next year we can only expect more. So that confluence of this desire for equality and this ever more expensive and ever changing and improving healthcare system, that is inevitably going to cause policy conflict.
Now, Paul, politically, I think I see an emerging idea to repeal Obamacare quickly, but not have that repeal take effect for a couple of years. Is that what you expect Congress to do? And is that because there are things that now the people now like about Obamacare, especially if they're among the 20 million who got coverage under it, and so they don't want to kick people out?
Right. I think that Republicans are caught between not so much policy challenges, which are significant but are workable, but they're caught between enormous political challenges. So they promised their base they're going to have a really fast, repeal of Obamacare. That means going through a route called reconciliation in the Senate. It's a budget maneuver. In a nutshell, they tried this last year. President Obama vetoed the bill. They found out they could only strip out the budget provision, so the subsidies, the individual mandate, the employer mandate. They're setting themselves up for a fiscal cliff, 2 or 3 years, when those subsidies would go away. The logic is you declare victory now, and then you move through regular order, through committee order, both in the House and Senate, on a replace bill. The problem is you're going to need 60 votes in the Senate, and Senator Schumer is going to have, I would say, virtually no incentive to break his caucus out.
The Democratic leader who will have enough votes to filibuster just about anything the Senate Republicans put forward.
They would need to break out 8 Democrats in that scenario. And I think that, look, just realistically, Senate Democrats are going to look at what Republicans have done over the last 6 years and say, the shoe's on the other foot now, and we're not going to let you strip away what we see as our biggest legislative accomplishment over this last 6 years. So either you're going to keep almost everything, or we're just going to say no. And that sets up a very poor dynamic.
If there's going to be something that replaces it, do the Republicans have the same goals? So, for example, to try to get almost everybody, if not everybody, to have affordable health insurance.
Sherry and I could talk about this. I think the challenge looking at this is A, who are we talking to? Who's our base? And I think Republicans are going to look around and see that for middle-class Americans who aren't eligible for significant subsidies or any subsidies at all, they're seeing very large premium hikes. And they're not protected against those premium hikes. Those people are complaining a lot, and Republicans are saying we need to fix that problem. But you've also got the 20-some-odd million people who are benefiting from subsidies either through Medicaid or private insurance on the exchanges who've got a relatively good deal right now. That's an awfully thin needle to thread. There are conversations you can have around addressing some of the problems on the exchanges right now. We could talk about subsidies, we can talk about HSAs, we can talk about all of those things. But the problem is the markets are under stress right now, and they could easily collapse if the insurers think, in 2 years there's going to be a huge food fight and the subsidies are going away.
What would you add to that?
Well, I think the other piece of it is nobody's got a really great plan to reduce the costs for those middle-class Americans. Even if you stripped away Obamacare completely, it would actually do nothing at all for the middle-class Americans who are suffering because their employer-sponsored insurance is getting more expensive and their deductibles are going up. If anything, most of these plans incorporate a version of the Cadillac tax, which is in Obamacare as well, which would actually make employer-sponsored insurance more expensive for all these people.
Meaning, if you get really good health insurance, there's a tax on that.
Yeah.
And what was the point of that in the first place?
Well, the idea behind it is that right now, the tax subsidy there's effectively a tax subsidy for employer-sponsored health insurance. If you get a wage increase, you pay taxes on the wage increase. If your employer gives you more generous health benefits, you don't pay any taxes on those more generous health benefits. The notion is that leads people to have excessively generous health benefits, and we should have a tax to strip that away and have people have more efficient health benefits. One could argue from here till eternity about whether that's right or wrong, but whatever it is, if you put a tax on it, it's middle-class Americans who are going to be paying that tax.
So there's a basic economic model underlying Obamacare. It's obviously imperfect because there are these frustrating premium increases that are taking place, although a lot of them are covered by subsidies for a lot of the owners of the policies. Still, it's kind of a sticker shock year for Obamacare. But the model is require everybody to buy health insurance. That'll get a lot of younger, healthier people into the pool, and then the insurance companies can use that money to keep the rates relatively manageable for the older, sicker people. And then for those older, sicker people or poorer people, the government helps to subsidize the cost. We know about the individual mandate and the subsidies. In theory, at least, it makes sense. What's the alternative model from the Republican side? Is it more market-based?
Well, I'd say this. I think that there's a consensus now, an emerging consensus that we've seen, that people with pre-existing conditions should not be charged more or denied coverage because of their pre-existing conditions. I think that's now part of the Republican plank. I think Speaker Ryan's A Better Way plan is interesting because
even should not be charged more for their premiums.
Right, I agree. So that's in the Better Way plan right now, and you can argue about how they go about
That's
it.
Paul Ryan's plan called a better way.
Right. You can argue about how effective that is, but I think one thing that I was saying several years ago when the ACA passed was, look, this individual mandate's not very strong. Premium increases are going to go up, and those young, healthy people are going to drop out of the market. There's risk selection against the exchanges right now. So we need a better mechanism for spreading the risk. I think there's broad agreement that you need to get those young and healthy people in the pool. And then you think, well, okay, if we make it more attractive for them, but we still have some back-end subsidies for older and sicker enrollees, and there are lots of mechanisms for doing that, can we balance it out? And Republicans and Democrats can argue about the richness of the coverage and open enrollment and all of those things, but that's more of a let's get under the hood of this and fix it than it is philosophical.
So you're saying that the Republicans hope to still get almost all the young, healthy adults in America to buy health insurance, but with incentives rather than the mandate. What would those incentives be?
Well, one incentive would be to say, look, if you buy and hold coverage at a certain date, when you're young and healthy, from here on out, as long as you hold coverage, you're going to get coverage that's cost at your age, not your health state. So over time, if we have this kind of buy and hold approach to insurance, and other federal programs like Medicare Part D have similar mechanisms, you buy in, you lose your subsidy, or you take a penalty if you don't buy in right at the beginning, and that penalty ramps up over time.
Does that have problems?
Well, it doesn't work. We've tried it.
That's a
because
problem.
That's a problem, right? So it actually this deal exists already for people who have employer-sponsored coverage. So under HIPAA, which is a 1996 law, if you have employer-sponsored coverage and you keep it, you can go into the non-group market and buy coverage as long as you have continuous coverage. But we observe most people just dropping their coverage at that point. They have no money, and so you actually see lots of sick people leaving employer-sponsored coverage, especially before the ACA, and going without coverage afterwards. And even if you look at Medicare Part B, you observe people who are actually not enrolling in coverage when they should, even though they face penalties ahead of them. I mean, the problem is, look, if everyone were rational, and if young 27-year-olds were thinking about what life is like when you're 45, this would work perfectly. If you know any 27-year-olds who can contemplate being 45, send them my way, because I've never seen one of those. So I think the problem is, in theory, if you did this and people were forward-looking and anticipated that they'd still be in the non-group market, because remember, if you're 27, you're not insured right now, the reason you'd buy coverage is because you don't think you're going to get a job that offers coverage between now and when you need it. So that's actually a very contingent circumstance. There's going to be a lot of people who say, I'm just going to take my chances.
If I understand Dr. Price correctly, he actually wants less health insurance in a way. I think he wants more of a direct relationship between purchaser, the patient, and producer, the doctor or hospital or pharmaceutical company. Is that your understanding?
I mean, I don't think he's come out and said that exactly, but he is a fan of the sort of traditional way of medical practice, a kind of 1950s way of thinking about medical practice, where there was not insurance companies and the federal government and others coming between the physician and the patient, and the physician is much more in control of that relationship. We're not going back there, no matter what anybody thinks or wants. Healthcare costs are just too high for most people to be able to be in that kind of relationship.
How much is the Republican plan, any major Republican plan, based on thinning out insurance in general and trying to, because I know that there's a thought that we use too much health care, or some people do, because there's so much third-party payment going on. If the insurance company or the government is paying the bills, we don't think about how much anything costs, and so as a country, we're not holding costs down.
Look, I think what we've seen in the RAND health experiment, which was done decades ago now, and others, is high-deductible health plans can get you to slow down spending.
High deductible, in other words, the first few hundred or
several
$1,000
$1,000s are
come
gonna
out of
be-
your pocket.
Right, but what we've seen too is that it's both, overuse and underuse. So we're cutting back on things we probably shouldn't be spending on, but we're also cutting back on things that we probably should be spending on.
Like what?
Like prescription drugs for chronic illness. So you have patients who, let's say they have diabetes, they might cut back on, getting a diabetic pump or insulin. These things, because they're looking at the first dollar cost. Interestingly, studies have found that even when these high deductible plans cover these things, people cut back anyway. So I think there's still a lot of room on experimentation and design. And one thing we should think about for design for these high deductible plans is say, if you have a maintenance drug for a chronic illness, it should be covered before the deductible. So that people who are the most vulnerable and sick aren't discouraged from
Right.
taking medicines we know keep them healthy.
Right. I mean, again, in theory, on paper, this works, right?
Well, it
because
does work.
if insurance, the typical notion of insurance outside of health is, you know, if you have a problem with your house, you pay for the fix on the problem you have. But if your house burns down, the catastrophic event happens, then you're going to be well covered. So if we go to the doctor for this little thing, that little thing, we would pay out of pocket. That's the deductible. But if we get cancer or need a certain prescription drug for the rest of our lives, that's going to be covered. Why doesn't that work in real life, or does it?
Well, so one of the things to remember is the Rand health insurance experiment was done back in, that's what we all rely on. It was done back in 1980. And the big contrast in that study is between people who have absolutely free care at the point of service and various other arrangements. Turns out that the biggest impact is having to pay anything at all when you go to the doctor. So the difference between having to pay $25 and paying nothing, it has an enormous effect on utilization.
That's why we have $5 copays
Well, nobody-
for things.
who has
and
$5 copays anymore?
$10
Nobody does. I mean, so we're now in a world where the most generous plans that are out there in the employer market look like among the least generous plans that were considered in the Rand experiment. Where there just isn't that much savings to be had anymore by raising deductibles. Once you're past a couple of $1,000s, it's largely just a question of whether you're paying the money or the insurance company is paying the money. People don't make sensible spending decisions at that point. We know this from Rand. The main effect of those deductibles is whether you go to the doctor in the first place. Once you go to the doctor, you just do whatever the doctor tells you. And that's true whatever your deductible may be. So it's not, I mean, I'm not a fan of free care at the point of service, but I think we have to be just thoughtful about how far we can go saving money with deductibles.
We just have about 2 minutes left. I want to touch on one other thing about Dr. Price. He doesn't seem to be a fan, based on his voting record in Congress, of a lot of funding for healthcare research. He was a no vote on an NIH funding bill. Are you familiar with his record on that? And
Somewhat. If you look at the U.S. economy over the last century, where we make big gains in economic growth is around innovation. And there's blue sky innovation that commercial firms are not going to do. So I think it's important that the U.S. has a significant commitment. That's one of our biggest advantages compared to, say, Europe. We've got a National Institutes of Health. We've got an NIH that makes these very big long-term bets on basic science that later on companies come along and turn into commercial products perhaps years or decades later. But what I would say is it's also, you know, the idea that everything in the NIH is not all created equal. We can also ask questions about what kinds of research are most likely to be most attractive and pay the biggest benefits down the line. I think that's a question worth asking. But at the start, do I think that, you know, this is something we should back away from? My answer would be no.
And Dr. Price voted against the Public Health and Prevention Fund. He called it a slush fund. If you defend it, what does it do? Because this, I guess, is going to come up.
Well, so, I mean, it's mostly defunded already, but I think the big issue there is whether the Centers for Disease Control particularly will have some flexibility in how to spend money and be able to target it at the places that are most vulnerable. Right now, the Centers for Disease Control budget is broken into tiny little pieces. They have very little flexibility. That's a more broad question.
All right, stay here, both of you. We're going to bring on some additional healthy evidence. Time for evidence-based politics, where we pour cold, hard facts on the overheated political rhetoric. During the election season, the opioid epidemic became a presidential issue when Governor Chris Christie spoke emotionally about a friend becoming addicted. And we heard from other candidates like Carly Fiorina, who told of the death of her stepdaughter. There has been government action this year. Over the summer, President Obama signed a bipartisan opioid bill, despite it being drained of some of the funds requested in an early draft. Given the scope of the problem, some action is better than none, the president said. Here is some of the scope of the problem. The Centers for Disease Control and Prevention finds that since 2000, deaths from opioids, including heroin, went up by 200%. And of almost 50,000 drug deaths in 2014, nearly 30,000 involved an opioid. One physician who treats opioid addiction patients firsthand says that the issue has been largely misdiagnosed. Our guest, Stefan Kertesz, professor of preventive medicine at the University of Alabama at Birmingham, says the common wisdom that prescription drugs are at fault is wrong. He joins us via Skype from Birmingham. Welcome to the program.
It's a pleasure to be on. Thank you.
What's wrong about that conventional wisdom about prescription drugs?
I think the better thing to say is that to speak about this problem as starting with prescription drugs involves a kernel of truth wrapped in several layers of mistaken assumptions. So what's the kernel of truth is that opioids can be helpful for pain for some and harmful for others, and the massive run-up in prescribing of opioids from 2000 to 2010 clearly contributed to creating an epidemic, although it wasn't always the patients being treated for pain who developed the addictions that unfolded. Right now, as we're in a period of a 4-year rollback in prescribing by physicians. In some health systems, the number of patients on chronic opioids for pain is down about 30 to 40%. But our epidemic is actually getting a lot worse, with a lot more deaths occurring week to week, as we see in the news. And that should really signal that a simple theory of opioids descending from doctors and pharmaceutical companies continuing and sustaining an epidemic is probably incorrect, even though we do need to roll back on prescribing, and we are rolling back on prescribing.
So let's put up a graph that you provided us from your work showing heroin and fentanyl outpacing prescription-type drugs like oxycodone, though it's still high. Are you also seeing something like this in practice that tells you that the prescriptions are just not as relevant anymore to the opioid epidemic?
Yes, absolutely. So when you go to a coroner's office, if that coroner's office really collects all the information available, including ordering extra tests for fentanyl, which is at additional cost, they'll find that most of the opioid overdose deaths are due to illicitly manufactured opioids like fentanyl and heroin. Sometimes they will find the medication type opioids that we typically prescribe, like hydrocodone or oxycodone. Often enough, those are in combination with cocaine or alcohol or fentanyl or heroin. It's relatively rare that the patients who die are the ones who have received an opioid and taken as directed from their doctors, although it certainly happens, and it does require significant caution by prescribing doctors when taking care of individual patients.
Do you think that there is still too much caution on the part of doctors? Because 20 years ago, the big story about prescription painkillers in the news was that doctors weren't prescribing enough of them, and too many patients were experiencing pain after surgery or with other serious conditions. Has the pendulum swung that far?
So we were at one end of a pendulum swing before, which was we don't prescribe enough, now we're going to prescribe a ton. Then we swung all the way over to prescribing essentially uncritically without deep and careful consideration of each individual patient and their personal risk for bad outcomes and watching them closely. We're now in the middle of a massive pendulum swing back, and unfortunately we're doing it so quickly and with so much fear among the doctors that a lot of patients are being left by the wayside. People are being withdrawn from medications they were on essentially stably for several years without their consent, without their understanding. And that practice of suddenly withdrawing a medication that a patient has been on stably for years is not a tested scientific approach, and it is not one that was recommended by the recent CDC guideline. And nonetheless, it's happening because of the social power of how we are speaking about this issue in the media, which I think we need to correct.
Let me bring our other guests in our studio back into this. You were nodding, Sherry. Does this become a public policy issue? We've been talking about it so far as a matter of doctors' practice.
Well, it has already become a public policy issue. I mean, we are pushing, trying to encourage doctors to prescribe less opioids. We're tracking opioids in a variety of ways. There are prescription drug monitoring systems. So there's already a lot of public policy around this. There's also policy on the other side. So Medicaid is now covering substance use treatment in new ways, and the Affordable Care Act packages include substance use treatment. So we're trying to deal with the addiction piece of it, and we're also, on the public policy side, trying to deal with the prescribing piece. The problem with public policy is it's such a blunt instrument. It's not that people who are prescribing properly that are really intended to be the brunt, to bear the brunt of this. Mm-hmm. It's the people who are prescribing drugs that got resold on the street or whatever. Hard to target that.
And I wonder then, Dr. Kertesz, if you think that so much of the focus on the part of politicians has now become doctors who overprescribe, because that seems like a more manageable target than to say the streets are out of control.
Right. You could take all of America's pain patients who are on opioids, put them on a ship in the middle of New York Harbor, and don't provide any opioids to them. And the size of our opioid overdose epidemic would be only slightly smaller than it is now. We know this from data collected in Massachusetts, where they analyzed who died and where and whether they had any kind of prescriptions. So the focus on doctors is easy. It's important because all of us have a solemn responsibility to use our prescribing authority carefully. But at the same time, the real problem is massive areas of the country where there is essentially no subsidized access to addiction treatment, including my own county. The medications that are proven and recommended by WHO and CDC are basically not available to anyone who's poor. And when you hit rock bottom, very often, you're poor.
Paul Howard, this becomes an Obamacare reform issue, I think, around one of the contentious pieces of Obamacare, which is all the things that are mandated to be in each policy. And Obama sees it as a matter of standards. Everybody should be covered for a minimum package of things. I think others on the other side see it as pushing the cost of everybody's health care insurance too high because everybody's being covered for things they don't need. Drug treatment, drug addiction treatment is one of those things that wasn't mandated before that is mandated now. Is that an issue?
Well, I think you saw state variation before in who was covering those. One of the Republican planks is returning more authority to the states. I think there's a lot more awareness around this issue right now than there was a few years ago. I think there's a lot more bipartisan agreement. You mentioned earlier there was a lot of discussion about this in the Republican primaries. President-elect Trump has spoken about it as well. There was funding for opioid treatment in the recently passed bipartisan 21st Century Cures bill. So I think there's a lot of agreement. This is a massive problem.
With this being a massive problem and everybody agreeing, should that be a part of everybody's health insurance as a guarantee?
Well, I think we're going to see, when Republicans talk about a slimmed down package, there's going to have to be debate around this. So when they think about the downstream effects of mental health and addiction, I imagine that's going to be one of the things that will be kept in a package.
Thank you all very much for joining us today for this important conversation. And that's our program for today. We're here each week at this hour, keeping an eye on the Oval Office and pouring cold, hard facts on the overheated political rhetoric. Next time, an encore presentation of Trump and foreign policy with three distinguished guests: Ian Bremmer of the Eurasia Group, Foreign Affairs magazine editor Gideon Rose, and Russian-American journalist and Putin critic Masha Gessen. I'm Brian Lehrer. Thanks for watching.